All right. We're recording. I'm also going to record on my phone because Zoom's been a little wonky.
Sure.
So just to make sure, just so students at least get the audio version. It's like a podcast. It's like,
It's cool. It
it's it's yeah,
feels
it's
official.
we're on Spotify, both video and uh uh
It's gonna be
audio.
thousands upon thousands of monthly listens to this
Right.
episode.
Thousands, not the 9 students that we have in this course.
Yeah,
But
exactly.
then most importantly, as we are recording, Phil Kubal, thank you for joining us this
No
evening
problem.
as we're recording, but I'm sure the students you'll watch it during the day, probably like multiple times, because students are going to watch this and say, this is the coolest conversation I've ever heard in my life. So I'm going to listen to it every morning for the next 2 weeks.
As
Um,
it should.
First of all, the first question before we get into your background, I wanted to ask. Now that you are this accomplished medical professional, you're a doctor, which is really cool to say, having known you before you were a doctor. Do you get sick of friends and family asking for medical advice?
It's funny. Not yet, mostly because I think a lot of people don't view me as a doctor yet. At least friends and family. It's still, like you alluded to, I'm still kind of in training, which is true. I am still in training. I'm in my last year of residency. But a lot of people are still like, "Oh, you're in school. You're
Hmm.
still learning." So thus far, it hasn't gotten too overwhelming. But listening to a lot of you know mentors and attendings and everything, I think that's coming. I think that's inevitable.
It'll definitely be coming from me. There's no doubt about it.
No doubt, no
Yeah.
doubt. Dr. Zimney, yes.
That's right. That's exactly right. Do you get that from patients ever, where it's like they know that you're not like you're still in training and so they see a difference?
Yes. Um, not as much as you'd think, actually, though, because I think a lot of people that end up coming to the emergency department or get admitted to the hospital and they see a medical professional of any sort, most people across the board are totally cool. They're happy to be seen by somebody. Obviously, you get your subset of people that are a little bit more picky and have higher expectations and want to be seen by an attending physician or an established physician, or nothing else. But overall, no.
Nice. Maybe let's start with a little bit of your journey from because you're a cobber, which is super cool. It's
No
where I
cobs.
roll comps is right. Can you talk a bit about your journey from starting at Concordia and where you're at now, right? Of how you got to that point and just a little bit what that journey has been like.
Yeah, definitely. So, like I said, Concordia graduated in 2016. So I'm from Hutchinson, Minnesota originally, and when I got to Concordia, I didn't know what I wanted to do, but um, you know, I did know that my dad, a healthcare professional, was a dentist. My mom was a nurse, so I kind of was thrust into the healthcare field just from the get go. And eventually, during college, I decided to pursue medical school, um, and I was fortunate enough to get accepted my what was that early senior year, late junior year of college, to University of Minnesota Duluth. Um, so it's kind of one of those things where I initially didn't really know what I wanted to do in medicine, but I was interested in rural family medicine. And Duluth is a great medical school to get training like that. They focus on that. So I went there for 2 years. I did my kind of preclinicals, I guess you could call them, lectures and more kind of lecture based learning, anatomy lab learning. Um, then after 2 years, I moved down to the Twin Cities and did my clinicals down there, my clerkships as they're called in medical school. Um, so yeah, so I lived in Minneapolis for a few years, graduated from medical school down there, University of Minnesota, and then through kind of a windy road, I found myself out here in New York City at NYU in neurology.
Yeah, what got you to decide, like what got you specifically interested in neurology? What not just got you interested, but made you actually want to formally say this is the path that I'm going to take.
Yeah, I think being honest, what started it is in high school. I got a concussion playing basketball, and I think that was like sophomore year of high school. And after that, I was always kind of like peripherally at least interested in the brain and what was going on with the brain. And then I played sports in college too, and that was kind of around the time when concussions were really a hot button issue, a topic of a lot of debate and kind of an area of a lot of need for more research and treatment and things. So I always was interested in the brain, which I knew. So pretty early on in medical school, I shifted from kind of the primary care rural medicine interest more into neurology, psychiatry, rehab medicine. Those were kind of the big three that I vacillated between. And I actually kind of tested out all of them. So I started, pursuing rehab medicine initially, which is kind of, after somebody gets a concussion, after somebody gets a traumatic brain injury or a spinal cord injury or something, those doctors kind of come into play and treat those patients. I found myself kind of less interested in that and more interested in psychiatry. So I actually started my residency journey in psychiatry up at in Fargo at the University of North Dakota. Um, but even before kind of starting my training at UND, I kind of came to realize that it was actually neurology that I was more suited towards. And there's a lot of overlap between psychiatry and neurology, but I'd say the big difference is neurology is more like hard brain anatomy and physiology, nervous system, kind of more diagnostics. You run more tests. There's a different kind of subset of treatments, and psychiatry obviously is more focused on mental health, which is
Mhm.
still a huge interest of mine. But long story short, I ended up switching from psychiatry to neurology, and NYU had a position open for me, so I accepted that a couple years back, and so yeah.
So how like in that process of switching to like specific areas, what leeway is there in the like medical training path of like do you get down too far where it's like, okay, I can't switch at this point, like I'm too far deep? Like how long do you have where you're like I can specialize now?
It's a great question because I did not know this going in. What you're told and what you see across the board, the majority of people is they pick a specialty and they stick with it. They build their resume towards whatever specialty it is. They do, kind of elective clerkships to meet people and get letters of recommendation, and they go and they train in that specialty. Um, for me, that wasn't the case. Obviously that it was far less linear than that. So what I came to find is it's totally doable. I think inevitably people, especially in something like medicine, where there is a lot of pressure on you. You're going to be doing years and years of training. You better pick something that you really like. There's a lot of pressure to do that, to pick the right thing. And what I found is I hadn't picked the right thing. And luckily for me, this is where it gets kind of gray, I think, is it depends on the program. But luckily for me, my program in Fargo, they were amazing. They totally heard me out and said, hey, it sounds like you have different interests and you're kind of focused on something different than the specialty of psychiatry. Let us help you get to wherever you need to go. So long story short, it worked out for me and it works out for a lot of people. And I think in general, it's something that is totally fine and doable, but it does come with stress and change and uncertainty even more than there was going into your initial residency.
Mhm. Yeah, I mean, it's like just having heard from you a little bit, how interesting of a process it actually is. And I want to dive into that process a bit further. Before I do, I want to ask, like, what else, is there anything else that like you wish you would have known as an undergraduate, right? Preparing for this career in medicine. What else do you wish you just would have known about the process, about the career path, anything like that?
Yeah, I think a lot, short answer, but the biggest thing is how actually grueling is the wrong word, how actually long it is. Obviously, everyone knows the amount of years it takes to finish medical school, well, go through your undergrad, finish medical school, get into residency, finish residency. A lot of folks after residency will do what's called a fellowship or a year or two of extra training in that specialty. So we're told, and the folks at Concordia are amazing across the board: biology, chemistry, biochem. All these professors that not only your teachers but mentors are incredible. They were when I was there, and I'm sure they still are. They're incredible at preparing you for that. Like, hey, this better be a commitment that you're ready for. This better be what you want because it is going to be a long road. But it's one of those weird things where becoming a doctor is such a dream for people that no matter what it takes, they're willing to just jump in. So what I wish I would have known is it's not all glamorous. Like it's not like, oh my gosh, I get into medical school, I'm a med student, I'm going to be a doctor. Like there's still more work to be done, you know. And that's not even to scare people away. I don't think people should find that piece of advice like off-putting to medicine. It's more like, hey, it's, if this is something you really want to do, amazing, do it. But just know that the allure and the kind of like the feeling of being, established and almost cool in a way. There's more to it. There's more to it. There's a lot of work in medical school. There's a ton of work in residency. And there's so many times where it's like, this is an absolute grind. And, I'm kind of on my last legs, but then you get done with your shift, you get done with that lecture, that test, and you're like, okay, this is why I did this.
Yeah. And you mentioned like there's more work to be done. Is there an emphasis? Because obviously, like there's continued education, right? Like after you're done and you're practicing, it's like it doesn't just stop there either. I mean, you're not in medical school, but have you had like conversations with folks around that too, of like what that looks like as you get 10 years, 15 years? Is it how regular of a continued education process is it, and what does that actually look like?
Yeah, it's actually built into the profession. Like you have to, continue your medical education. You have to keep up with the current research, the current clinical trials, the standards of care. And to do that, you have to take tests. And at least in today's day and age, it's kind of built on you're given kind of the seminal research papers in the field. You read up on them, you take a test based on them, and that's how you kind of formally, get this designation for obtaining, continuing medical education. But it's for a reason, like especially in a field like neurology, where even 20 years ago, so many of the conditions we're treating didn't have a single treatment,
Yeah.
and I'm thinking of things like multiple sclerosis, even Alzheimer's disease, a couple of treatments just became available in the last couple of years. It's because these clinicians have to keep up with their continuing medical education. Um, but then on the flip side, it's it can totally seem like, oh my gosh, this is never over. Like we're going to continue taking tests our whole life. But from what I hear, it goes from studying for things that will never be relevant to me to studying for things that I'm super interested in and are going to be important to my patients.
hmm Yeah, no, and I think that medical training piece we've talked about in class too. I mean, we've talked a lot of medical school and training, folks getting into specialties. But I was curious, like from your perspective, what like maybe, for lack of a better word, gaps, right, in whether it's your medical training or medical training in general that you've seen has become apparent, once you like start actually practicing a bit, right? Like once you're actually providing care, what are those gaps in medical training that you had noticed, or that you have noticed now that you're really getting into it?
Yeah, I think for me, and I think if you asked other residents, other practicing physicians, they'd have different answers. But you're really not taught the actual nuances of like insurance coverage and like what patients are actually able to get in terms of treatments or diagnostic tests and things. At my program, I'm fortunate enough where we get some like exposure to that, some guidance on hey, you're at this clinic through this, healthcare kind of facility, and these patients qualify for this kind of specialized scan or something, or this new treatment. But really, for me at least in general, that is not something that was intuitive to me at all. Um, and it becomes even less intuitive the more you go out and you deal with patients of all sorts of socioeconomic status, all sorts of backgrounds, geography, even. So that's a huge one. And then I think just in general too, the expectations that a resident has beyond just learning how to practice medicine, but um, it's more than that. You become an educator. You have to teach the medical students, that you were in their shoes just a few years prior. You still have to prove yourself to the attending physicians, as worthy to continue on with your training and all this stuff. So it's things that in retrospect seem really, really easy to understand and expected, but in the moment it wasn't for me.
Yeah. Was there a big, was there a gap in anything that was like, okay, I was taught this and now I see it in practice and it's a lot different than what I thought it was going to be?
And practically speaking, they're like, yeah, and I'm not sure if your students, if they're interested in healthcare, if they're taking biology classes or chemistry classes, or you're taught so much of the details of like how our bodies work and the pathophysiology of diseases and things. You get into the real world, very, very few cases are actually textbook. Like there's nuance to every patient that comes in. Even if you think you have a slam dunk diagnosis, you have to consider five or six other things. And that, again, it's something that you come to understand and maybe should expect, but it was definitely a surprise to me, and it still kind of continues to be a surprise for me.
Sure. And what you said before too is so interesting that like the complexities of like insurance coverage and that sort of thing, and like not necessarily like having had that formal or extensive education on that before you actually see it. Why do you think that? Do you think there's a reason for that that is just not talked about, or is this just an oversight in the system?
A bit of both. I think it's probably because you're going to learn it eventually. It's almost like, there's very few things in medicine that you learn on the job, because you're in training for a billion years. So they try to kind of hash out all those things that you don't have to learn when you're eventually kind of an independent practitioner and prescribing medications on your own and things. But so I think when you're a trainee, it's not as emphasized because it's understood that when you get into practice, that will become like very much like intuitive and something that you come to know day in and day out. And also, it totally depends on where you practice and what kind of practice you get into. If you're going to do private practice, if you're going to do community practice, if you're going to go somewhere rural or somewhere super, it's like a big city like New York, all of that is really difficult to, I think, prepare each individual resident to. Um, but still, if I had my way, it would be a little bit more ingrained in us as residents.
Yeah. And I want to move to the probably easiest topic that I think everyone in the nation agrees with, which is obviously the U.S. healthcare system, which is just a
Oh,
very
an easy one. Yeah, yeah, yeah.
easy one. Uh, from your perspective, as a neurologist, this is maybe starting too broad, but we can dive down deeper from this. What do you see as maybe the biggest strengths? Because I want to make sure that we emphasize that there are some real positives in the American healthcare system, as well as what are maybe the biggest weaknesses that you've also seen.
Yeah. Again, like you said, super easy question. Same answers across the board, I'm sure. I would say, to keep it brief, like some of the strengths, and things are changing. Things are different than they were a year ago, obviously. But I think I've always seen American healthcare being kind of on the forefront of cutting edge research. And you, as a neurologist, like I alluded to earlier, a lot of the conditions we treat are untreatable by definition. We don't know a lot about the brain, the nervous system. It's still a mystery. But in America, we have access to cutting edge clinical trials for new medications that may be beneficial down the line, that are in the works of getting approval from the FDA or something to be used in practice. So just in my very, very limited experience, getting patients that I think could benefit from not experimental, but more, early on promising treatments. That is something that I still feel is unique to America. Um, and also just, again, say what you will about insurance companies and whatnot, but the quality of healthcare overall, to my limited knowledge, is pretty good. It's pretty good. There's a lot of physicians that really, really, really take pride in their work. And I don't even mean to say that isn't the case in other countries at all, but in you know, in my experience, that has been the case. So the majority. Now the weaknesses on the other side of the coin to that is there is an overwhelming, you know, disparity in who can get healthcare, just in general, by way of it being privatized and insurance companies getting in the mix and dictating a lot of decisions. That almost inherently makes things tricky for a lot of people. And again, you know, we're not the only country that has that system, and there are pros and cons. But you know, you look at other countries that are more public and have kind of more you know, just ingrained coverage for medical care. There are a lot of upsides to that, especially when you know you're in a program like in New York City when we train at a very public hospital. When you see patients that are uninsured or are dependent on um, you know, just getting the bare bones medical care and they still can't, it gets frustrating to see that continuously falling through the cracks.
Yeah. Yeah, and that actually leads me to my next question because it's important to hit on this is that about these types of inefficiencies, I guess it's maybe a dehumanizing way to describe it of like folks not receiving care or not receiving proper care. But are there any like inefficiencies in the healthcare delivery system that you find like particularly frustrating or that just drive you crazy or particularly problematic even?
The biggest one um, would be when you know something's going to be good for a patient, like when you're taught this, we see it in our lectures, we hear it from our mentors, like order this test will dictate this treatment, and this treatment will be beneficial for the condition you've diagnosed, and insurance won't cover it. You know, it's or there's you know, 100 hoops you have to jump through just to get the initial diagnostic test approved. It's really frustrating, and it takes a long time. It takes too long a lot of time. Um, and that, you know, it's hard not to get bogged down in things like that. But you know, like I said earlier, sometimes that does end up being a pro. You know, sometimes
Mhm.
insurance coverage paying for those things that are early on, they're not fully approved, or you know, they're not fully established as the treatment quite yet. Sometimes, you know, you get the upside, but that's definitely the biggest frustration I have.
Sure. And you being like a specialist in the field, what do you see as the role of specialists like neurologists in improving patient care and navigating some of these systematic challenges? Like how that's maybe different from a non-specialist, I guess you could say.
Yeah, no, I mean, medicine's changing. Medicine's way different than it used to be for a billion reasons. But in terms of the difference between kind of a primary care provider, you know, like family medicine or internal medicine, or kind of more general medicine, you know, to a subspecialist like neurology. You know, for me, I see my role as not only being somebody that has kind of an expertise in one little thing, but isn't as well versed in other things.
Hmm.
It's educating kind of a primary care doctor when to refer to me, because in neurology, especially dementia, you know, and that's kind of the area of neurology I'm most interested in is Alzheimer's disease and dementias. It is extremely prevalent. It's extremely costly, and it's extremely you know, detrimental to patients and their families. So I feel like as a subspecialist, not only am I supposed to be kind of an expert in understanding those diseases, it's an expert in how to, you know, educate primary care providers on how to recognize early signs, or how to recognize when somebody might need a little bit more specialized care. Um, but the fact of the matter is, you know, the majority of our patients are going to their family doctors first, or their primary care providers first. They are the absolute backbone of the medical system, and they work the hardest. They're the busiest. They're the most important. And you know, if if they don't know when to refer, what to look for, it's not a fault of theirs, it's a fault of mine, you know?
Hmm.
So there's excitement and some pressure on the subspecialist in that way.
Interesting. And does this different parts like structure of the system, I don't know if I'm wording this right, but like kind of communicate with each other effectively? You know what I mean? Like you're talking about kind of educating folks when to refer to you. What does that look like? Like from a patient standpoint, I don't even know, right? Like I've been to doctors, but it's like, okay, someone refers me to a specialist. How is that communicated to the patient? How do you navigate this really complex system? Is there a gap there and how that is both communicated internally, like, doctor to doctor, like what you're talking about, but also, I mean, where does the patient get kind of left off in this process of like
Yeah.
just kind of assuming they know, if that makes sense?
Yeah, no, it's not straightforward. It totally depends on the healthcare system the patient's in, where they're at, how accessible specialty care is. I mentioned, obviously the differences in rural healthcare compared to urban healthcare and kind of accessibility to more of the specialized tests and treatments. The in theory, what happens is patients will come to their primary care provider and have XYZ concern, and the primary care provider, if they have the means or if they have the kind of the opportunity to refer to a specialist, great, do it. That should be the norm. It should be how it goes because the patient needs to get the best care possible. But oftentimes that just is not possible if they're going to, a rural place in South Dakota or Minnesota or something. It's more limited, and the wait times for the specialists are sometimes years,
Yeah,
you know,
crazy.
and it's up to the primary care provider to do the best they can to hold them along. But what I will say too, which I think is a great thing, there's a lot of communication informally between colleagues. I know so many people that have a friend that's a cardiologist or have a friend that's a hematologist or a neurologist. And, they know that getting their patient in to see that hematologist is going to take 8 months, but they're worried. They can reach out. That's
Mm.
normalized. And I think it should become more normalized. It's tricky because it takes time and
Yeah.
it's not billable, but, um, I think that's a cool thing that's kind of being normalized as time has gone on.
That's interesting because it's probably something a lot of people don't really realize or you don't really see, right? That's not something you
Yeah.
see up front. Um, so one of the things, I mean, probably the biggest through line of this course is on the social determinants of health and on healthcare disparities. So maybe just even in your work with what you've already done, whether that be education or you actually practicing, how have you seen maybe firsthand how the social determinants of health, things like income and education, race and ethnicity, gender, all that sort of stuff, how have you seen that firsthand affecting actual patient outcomes? Because that's the thing we connected to, right? It's not just some ethereal thing of like, there are disparities on the basis of income or race, it actually showing how that directly correlates to either negative or positive health outcomes. How have you kind of seen that manifested in the system?
Yeah, it's super important. And it's super interesting. I had very little kind of knowledge of the actual the reality of how important healthcare disparities are to know as a physician. But in my training here in New York at this program, we're fortunate enough to spend most of our time. We spend our time at 3 hospitals, but most of our time is spent at a large kind of corporate, privatized sort of healthcare system in NYU, and then the other kind of huge chunk of our time at the oldest public hospital in the country, Bellevue Hospital.
Mhm.
And I can't even tell you how different the the vibes of practicing are, how different the patients are, how different the pathology that these patients come in with is. And it sheds a light because at NYU, again, as a generalization, at NYU, patients are insured. Patients are typically on the higher end of the socioeconomic scale. People are more supportive or supported. They have more family, more of a stable income, more stable housing, and they come in and they can afford to get the most cutting edge treatment, the most cutting edge care. Whereas when I spent time at Bellevue, the vast majority of our patients are uninsured. Many of them are unhoused. Many of them are alone, you know, and they come in. By the time they come in to seek care, it's unfortunately, their disease, their symptoms, their whatever it is, has progressed to a point where they're so sick. So, I tell people that the patients I've seen at Bellevue, I truly believe I won't see sicker patients in my career. These people are really, really, really struggling. But it's just so amazing to see them come into Bellevue and to see my co-residents, us that practice at both hospitals. The attendings oftentimes practice at both hospitals. Doesn't matter. We provide care, the best care that we can, to everyone. It's just kind of we're at the mercy of the healthcare system. So it absolutely has shed a light on how different patients are depending on these healthcare disparities.
Yeah. Interesting. One of the other areas that we talked about too in class is the role of chronic disorders and like chronic illnesses and how that's directly correlated, right? And how we have right now a rise of chronic diseases. And there's a lot of reasons for that are both like there are actually some positives, right? Because people are living longer comparatively in history. So there are more chronic disorders, but especially in the United States, things like poor diet, things like systemic issues are creating more chronic disorders as folks are, not going to that preventative care. And so they have longer, negative health related outcomes. And so curious, like, because obviously there are chronic conditions as neurological conditions, clearly, that require that sort of long-term management. How have you seen these type of disparities that you've talked about in healthcare access impact patients with specifically chronic neurological disorders?
It's honestly, it's very similar to when you see people in the acute phase of their illness. At NYU, these patients are coming in, in general, less advanced, less kind of progressed in terms of their chronic illness. And in the neurology world, their Parkinson's disease has already been, treated. They're on a treatment. They're usually pretty stable. It's just kind of the natural course of the disease is what is, leading them to seek more care. Whereas at Bellevue, it's oftentimes we make a diagnosis and there isn't much more to do at that time because they're so far advanced. And I think a huge reason, there's a lot of them, but a huge reason is just the frequency at which patients can have care. The frequency at which they can see a provider at NYU or at more privatized places. It's much easier. It's much easier to see a provider every month or every other week, depending on what they have. Whereas in the public setting, that's really, really difficult. It's really difficult to schedule these frequent follow-ups and make sure that their diabetes is under control, make sure they're taking their blood pressure medicine, make sure they're taking, their memory medicine for Alzheimer's or their Cinemet for their Parkinson's or something, just keeping tabs on them because they have a billion other things going on. They're unhoused or they have a lot of children or grandchildren that they're all taking care of. It's just their lives are so much more stressful. So I think in terms of chronic illness, that's a huge reason why, unfortunately we see folks that are of, a lower socioeconomic standing, they're suffering from more healthcare disparities. Their chronic illnesses progress quicker and they do worse.
Well, I don't want to just all talk about, I mean, these are really important conversations, but I also want to end on a couple notes of kind of looking ahead, right? As we think of the future of healthcare and maybe some last bit of advice for these students. But what maybe changes or innovation in medicine, whether they're happening now, whether it's something that's being talked about or research that's happening. What are the things that actually excite you most right now about, especially neurology, right? Of where we're going in neurology.
Yeah, there's a lot of exciting things happening in neurology specifically. I'll just put a plug in. Like I said, I'm interested in Alzheimer's and related dementias, and you know, classically, these are things that are just untreatable. That you get diagnosed with this neurodegenerative progressive disease that will inevitably, you know, it progress, and you'll get worse, and you'll become dependent on loved ones, and you know it's really a difficult thing. But in the Alzheimer's world, like I had mentioned, there are now two FDA approved disease modifying therapies for Alzheimer's. And that just means, again, they're very modest benefits. There's side effects. These are things that are very early, but disease modifying means it actually slows the progression of the disease. We have never had anything like that before. And these two medicines, lecanemab and donanemab, they have been proven to slow the progression of the disease, albeit modestly. But it's a step in the right direction. It's super exciting. It shows us that, hey, there's hope for some of the most, historically untreatable neurodegenerative disorders. But I think, just that being an example, a very, very small example of what I see a lot, that's the case for a lot of medicine. I mean, you mentioned it. People are living longer. People are, they have more chronic illnesses, largely because they're living longer. And that is a good thing, that is a good thing, that folks are able to live longer. That's a testament to modern healthcare, the research that we're doing. And it's really hard not to be excited about the future of healthcare when you think of that.
Yeah, for sure. The last thing that I want to ask about is you kind of already hit on it with your journey and everything, but think about these students as covers, right? You've sat in the same seat as these folks. They didn't have me as their professor, so obviously already a step above. I'm just kidding.
No, it's true. It's true. Very true.
For students considering, medical school or healthcare careers, what advice, some last minute advice here, would you give them? And it can be whether, sociologically, from a sociological perspective or just a practical perspective. But what should they know that maybe you want to part some last bit wisdom on?
Yeah, definitely. Well, first off, I'll say I'm jealous of you guys. I mean, this is the best time. I loved Concordia, still love Concordia. Some of the best memories. It's an amazing place. Truly, you're at an amazing institution. You have an amazing instructor in Dr. Zimney. But what I'll say, sociologically, despite some of the negative things we talked about, it is super exciting, and it's a field that is so rewarding, and it's so needed, and it's important. And that's just healthcare in general. Whether you go on to medical school, dental school, physical therapy, you become a nurse practitioner, a physician assistant, whatever it may be, you have a pivotal role in the lives of other human beings. And I feel like a lot of other careers cannot say that. They're still important, but it's a very unique aspect of healthcare. So that's one thing. But practical advice, I would say, if you are interested in medical school specifically, find a mentor. And there are a ton of them. I know for certain at Concordia, there are a ton of them that are amazing, and they're all wealths of knowledge. But I know for myself, I was clueless, despite being surrounded by a lot of pre-medical people, having parents in the medical field. I was still clueless as to how the process goes. And if it wasn't for me sitting down with, some of my mentors, Dr. Rutherford, Dr. Asfig, both Dr. Rutherfords, who I think are still there. They're amazing. Everyone in the science world at Concordia, um, you know, grab 15, 20 minutes with them, a meeting, just to walk through best next steps. Cause it is, there are steps that you'll need to take to apply and to get accepted and all this stuff. But, if it's something you're interested in, absolutely, it's worth it to take a swing and meet with a mentor and go from there.
I love it. I love it. And it is exciting to be at Concordia in general, but especially, the work that the healthcare, the health profession school is doing, Center of Population Health, getting this well-rounded perspective. I mean, Concordia is a cool place to be right now. And it elicits cool people like Phil Kuball. And I appreciate you coming and talking with us today.
Of course.
Really, really appreciate it. So, y'all, for the students, of course, encourage you to write some weekly reflections on this conversation. We will certainly talk more about these subjects, but I guess you can't really join me in thanking me, Phil, thanking Phil for being here. But you can, I don't know, maybe I'll share
I'll,
Phil's.
what I'll say is thank you, Sean. This is amazing, and also, I'm totally open to questions. Like if you have questions, if you have any sort of follow-ups, please, Sean, I'll give you my email. I mean, I think you have my email. Please reach out. It's totally welcome. It's something that I'm interested in. Is kind of just chatting with, especially people at Concordia about medicine. So please
I love it.
reach out.
I love it. We will absolutely do that. Thank you again, Phil. And students, we'll see you next time.